Welcome to the Boston Children's Answers Parentcast. I'm your host, Jennifer Arnold. As a doctor and a mom, I'm passionate about helping kids stay healthy and happy. So join me as I sit down with fellow experts from Boston Children's to find answers to the questions that matter most to you and your family. Hi, everyone. Happy to have you join us. Today, we're talking about one of my favorite topics, bone health. You might be thinking, okay, kids, how important is it to really talk about your bones? Bone health is more than just making sure you don't have a fracture. Bones are critical for protecting our organs and our body, giving us strength, ability to move around. We're going to learn a lot about how you as a parent can help promote good, healthy bones. But as always, let's start off today with our parent question.
Hi, my name is Grace. My son Billy doesn't seem to be growing as fast as the other children in his class. Could his short stature be related to his bone health issues?
Thank you so much, Grace. And I completely understand the worry of thinking about your child's growth and particularly their bone health. So here to help discuss bone health today is Dr. Nora Renthal. She is a pediatric endocrinologist and also medical director of Boston Children's Bone Health Program. Thank you for joining us, Dr. Renthal.
Thank you, Dr. Arnold. I'm excited to be here.
I am thrilled you're here because I have gotten the chance to work with you more and more since I've joined Boston Children's, and we're getting to work together now in the bone health program. So I wanted to start off, though, by asking you, how did you get into this field, or what drew you to it?
So I'm a pediatric endocrinologist, and for people who don't know, an endocrinologist is someone who specializes in the way the body talks to itself. Different parts of the body need to coordinate their activities to keep us healthy, and they do that through hormonal signals that are chemicals in the blood. And I've always found that really fascinating, like how the body stays in what's called homeostasis, or at a status of health, by one organ talking to another organ. And so how does a pediatric endocrinologist get interested in skeletal health? There's actually a lot of different specialists that work in skeletal health for kids. And that's one of the things I like about being a pediatric bone doctor is I get to work with surgeons who take care of the structural aspects of the bone, physical therapists who help with patients and their movement and their ability to do their physical tasks of their day, nutrition, because we'll talk about this, but nutrition is so important to skeletal health. And then there's the endocrinologist who's focusing on the way that the world is interacting with the skeleton, the hormonal milieu, the blood, and the signals from the body that keep our skeleton healthy and strong. And there are some hormonal signals with big, long names that are always interacting with the skeleton. Vitamin D is one with a short and easy name, but we'll get into it. So I really like a multidisciplinary approach to care. I like the opportunity to work with lots of different types of medical providers. That's what really brought me to it.
Well, I love the fact that healthcare is a team sport, and there's so many different experts involved in the care. So I love to hear that's one of your passions. It's also one of mine, just like bone health. So yeah. Speaking as someone who doesn't take their bone health for granted, I have a skeletal dysplasia, I have a bone dysplasia. My parents told me to take care of my bone health. Now I have kids who have skeletal dysplasia, and I'm thinking about their overall bone health. So, but for every person, bone health is really important, and I don't know that we all think about it all the time. Mm-hmm. What would you say are some important things for parents to know about helping their kids to have healthy bones?
I think it's important for all kids at every stage of their development. Skeletal maturation is something that happens exclusively in the childhood years. So our bones mineralize from actually intrauterine development inside the mother's womb all the way through until our early 20s. And then those are the bones you have for the rest of your life. So it's really important for us to focus on kids and the strength of their bones throughout childhood. Easy things that we can do. Like you said, your parents told you, drink your milk, eat your fruits and veggies. Those are fundamental things to keeping your skeleton healthy. So why do we ask patients to drink their milk? It's because that's a very easy, bioavailable source of calcium. And so we focus mainly on two things, on the calcium and then vitamin D. And vitamin D is called a vitamin, but it's actually a hormone. And what it does in the body is it helps your intestine absorb the calcium you eat. So you have to have enough calcium in your diet so that there's something to absorb. And then you need vitamin D so that your body has the ability to absorb the calcium that you're eating. So those two things together work hand in hand to help kids mineralize their skeletons.
So, I think generally parents have heard vitamin D is important, calcium is important. Are there other things that are also important?
A good point to be made is that calcium and vitamin D are important to not have too little of, but having an excessive amount of calcium or an excessive amount of vitamin D doesn't turn you into Iron Man, for example. You just don't want to be deficient in those categories. Our bones are actually, it seems like it's just like sticks, right? It doesn't seem like it's a living thing, but actually it's a very slow growing, but still very much alive living thing. And your skeleton is responding to signals from the environment all the time. And one of the most important environmental signals is what we call mechanical loading. It's a fancy word for exercise. Like every time you put pressure on your bones are sensing the pressure as a mechanical force and then sending hormonal signals to the other cells inside the skeleton. Hey guys, it's time for us to put calcium and phosphorus onto the skeleton. We know this is true from a couple examples.
Yeah.
So astronauts, when they go into outer space, they don't even have gravity mechanically loading the bone, right? They're up there floating around. They don't have a weight. They immediately begin to get osteoporosis or disease of porous bones. And that's because their bones aren't receiving these ever so important mechanical signals that tell the cells like, hey, let's put calcium and phosphorus onto the skeleton. So astronauts have to exercise rubber banded to a treadmill. Here on Earth, what do we want kids to do as much as it's possible? Go outside and play.
Yeah, easy as that. Get active. Now, what about those kids who may have, maybe a physical disability who can't go out and run or play sports? Anything special that, we think about in those special populations of kids?
Yeah, 100%. It's even more important, I think, to work with your physical therapist, your rehabilitation doctor, do mechanical loading of the bone to the extent that your child is able to do it, even if it's just time in the stander. And then build your strength over time. Your physical therapist will be able to work with your child's particular body and their particular needs and their particular condition and come up with a routine that works for them. But I'm frequently writing notes for my patients saying how important it is, just any amount. And that's why I give the example of the astronaut, because you don't even think about the gravity.
No.
But just moving your body against gravity is something that sends this signal to the bones to mineralize themselves.
That's great. I think all of us think about milk as a good source of calcium. I think many of us know that, exposure to the sun helps to improve your vitamin D. But can you talk us through good sources and what is it about the sun that helps us from a vitamin D perspective?
Those are really good questions. Okay, so diet is paramount. You mentioned milk. That's true. A lot of us, like myself, I'm lactose intolerant, so I can't have regular cow milk. But milk substitutes are abundant these days, and you just want to read your labels and make sure that it says fortified with calcium. Also, cheese substitutes, yogurt substitutes. Some of our dark leafy green vegetables are great for calcium, but just bear in mind, you have to eat like your own weight's worth of spinach to get the same amount of calcium from the spinach as in 1 glass of milk. 7 cups of broccoli is the same amount as a glass of milk.
Wow.
So no child is going to sit down and eat 7 cups of broccoli.
I don't think so. That would be a tough sell.
Right. But what I tell families is those foods are healthy for you for other reasons. They contain trace minerals, good fiber for your diet. We all know that broccoli is important to add. So a broccoli cheese casserole, now you're moving in the right direction. Just add foods with calcium in them. And then you mentioned vitamin D. Our body will synthesize vitamin D from the sun. We live in New England. It's really hard to get enough sunshine. And then if you live in a really sunny place, like I'm from Texas, you will get a sunburn almost immediately before you get, enough vitamin D to meet your daily needs. So really, most people are taking a vitamin D supplement that might be mixed in with their multivitamin. Okay. And then if you need more, your doctor can tell you. There are some foods that contain vitamin D, but again, a hard sell for a lot of our kids, like tiny oily fish. I keep trying to convince my patients to eat more anchovies and sardines and shiitake mushrooms, and I'm not having a ton of success there. But if you get lucky and your kid has a very sophisticated palate, go for it. Lots of broccoli, lots of shiitake mushrooms, lots of tofu, lots of chia seeds and sesame seeds.
All right, good news. My kids like tofu and shiitake mushrooms, so hey.
That's great. Well, their mom's a bone doctor.
Yeah, maybe. Trying to help, maybe. Still a tough sell sometimes. That's great. So, Dr. Renthal, what happens to kids who may not have healthy bones, or when kids have unhealthy bones?
Yeah. I mean, the biggest risk factor is fracture. Now, all kids will fracture. In fact, half of all children during childhood fracture a bone. But when we're evaluating a child in the clinic, we're thinking about multiple things. We're thinking about what bones you fractured. If you're fracturing your big, long bones and you're having more than one, so we say 2 big, long bones before age 10 is something that might send up a red flag. And that doesn't necessarily mean you have a skeletal health problem, but it's one of the red flags that we're looking for in the clinic. We exclude things like wrists, fingers, and toes, because kids are going to fracture wrists, fingers, and toes, and that doesn't necessarily mean you have a bone disease. But it's these big, strong ones that really aren't supposed to fracture in childhood that we would look out for.
We think about bone health as we get older. We're worried about things like osteoporosis. But what are some of the bone problems that can happen in kids?
So many of the same things that we see in adults, we also see in kids. But when you're evaluating an adult, say with osteoporosis, it's their lifetime of exposures that led to that condition, and mixed in with genetic factors. The same is true of children, except in kids, when things are happening earlier in life, it may be because of a genetic difference. That person has a genetic difference that's causing the osteoporosis to happen earlier. So we broadly divide bone disease in kids into 2 main categories. Things that are what we call intrinsic to the bone, i.e. it's a part of the skeleton. Those are primarily genetic differences.
Yep.
So our bones are made up of 2 main components, say. The collagen that gives the bone some flexibility, and then mineral. That's the hard part of the skeleton that gives it its strength. But you don't want it to be all of one or all of the other. If it were all collagen, our bones would be bendy. We'd be like Stretch Armstrong. We'd be like a rubber man. And if it was all mineral, you would be brittle. You would break like chalk. A chalk doesn't have a flexibility. So a bone is a really magical thing, right? Because it has a combination of the flexibility and the strength. And so children can be born with differences in either the collagen part or the ability of the body to put mineral on the skeleton. There's an example that we talk about frequently. Many people want to know, does my child have brittle bone disease? Or the medical term for that is osteogenesis imperfecta, or OI. That's actually a disease of the collagen part. So the collagen fibers don't fold up with each other the right way. And so you're lacking that flexibility. And then there's the issues of the skeleton interacting with the environment. So what we see a lot of times is that kids aren't getting the right nutrition. Or maybe they're eating all the right nutrition, but they have a difference in the way their body absorbs their nutrition. If you have an intestinal inflammation, if you have a shorter intestine than what would be healthy, all of those problems can lead to reduced intake. It is either not coming in or it's going out too much.
Yep.
And then other problems that can occur in kids with chronic poor health is that the inflammatory state is really bad for your skeleton.
And maybe in those situations too, there may be a component of extrinsic or external impact, right? Sometimes if you have another health condition that might affect your absorption or something of that nature.
We
kind
tend
of a
to
combo.
think, kids with other chronic health conditions frequently are on medications that can be toxic to the bone. Frequently, when you're not feeling well, your nutrition can suffer. And then if there's any aspect of your chronic health condition that's leading you, to be inflamed or unwell, then that can affect your skeleton.
That
so
makes sense.
It's important for parents of chronically ill children to also think about, am I giving my child vitamin D? Is my child getting enough calcium? Am I talking to my doctors about my child's skeleton?
Yeah. It makes a lot of sense. I mean, as a neonatologist, we worry about bone health in premature babies for these reasons. They don't have the ability to develop some of that time in the womb to create healthy bones. And so when they're born premature, they can have higher risks of fracture.
Such a good point. Those last few weeks
are important.
Yes.
For bone development.
For bone development. That's actually when the humans are mineralizing their bones the most.
Yep.
So every week that you're born premature is putting your skeleton at risk. Now, good news, you get caught up.
Yes, we have ways of monitoring and providing that. So
right, and you have a good medical team.
Yeah.
But I frequently do see. I think I have a patient in clinic tomorrow to help with the team.
Yeah.
For a baby that was born premature, and we just got to get them right back on track.
So many things can affect your bones, which is what I'm hearing. Bones are important. So obviously, let me just make it a little bit personal, talking about those intrinsic causes of bone diseases. So I have a type of skeletal dysplasia, which is caused by a genetic condition. It's one of the rarer ones that affects collagen. It affects collagen in a way for me that it doesn't necessarily make my bones brittle, like osteogenesis imperfecta, but it affects the way the bones grow and their size. I wonder how many folks know much about the different ways the bones can be impacted. So bones can be impacted not only by how strong they are, but how they grow. And so for my condition, I've had to have a lot of surgeries to help correct the abnormality related to how my bones grow so that I could, move around. So there are many different skeletal dysplasias. Oh my goodness, there's over 300. And so I'm excited to work with you because I'll get to help take care of those kids soon.
Absolutely. We need you in our clinic. I think, broadly speaking, we tend to conceptualize, we meaning doctors on the medical team, as what's called metabolic bone disease or diseases of the mineralization of the skeleton, and then skeletal dysplasias, which are primarily genetic conditions that affect the way that the bone's shaped in the very first place.
Yeah. Yeah, and I'm not sure that everyone realizes when you have a skeletal dysplasia that oftentimes results in short stature, but that it also is an intrinsic bone problem, and that can lead to other health conditions and complications that, it's important to look out in this population for.
Absolutely. I mean, your skeleton holds all your organs in your body. It gives you the ability to move. And then there are also very fine nerves that run from your eye to, your brain, and those nerves are passing through your skull, which is a bone.
Yep.
So if your bones aren't growing well in your skull, complications of skeletal dysplasia could be hearing loss, vision loss, pretty serious.
Yes. Sleep apnea, paralysis, neurologic problems. Yes, because all the bones that grow abnormally, either in size or, form, ends up leading to nerve impingements, potentially respiratory problems, breathing problems. Because the bones are everywhere. Mm-hmm. They affect all of the functioning of your body.
Yeah. And I think at this time in modern medicine, we're not really diagnosing skeletal dysplasia in an older child. I would say the evolution of genetics is such that we can diagnose skeletal dysplasia quite early. So for moms and dads that are, listening to the podcast, for example, I don't want them to have the takeaway that my child maybe not growing that fast. Maybe it's a skeletal dysplasia because for the most part, it's not. A lot of times those things are something else. It's an environmental cause. It's an endocrine clinic and in the metabolic bone health clinic, we're 99.9% of the patients are having an environmental problem, whether it's a chronic health condition, whether it's poor vitamin D intake, whether it's nutritional. Those are the things that we're seeing the most.
That makes sense. And, I think talking about our patient, right, that had the question about concern for her son about how her child is growing, that, how do you sort of evaluate a parent's concern for poor growth or worry about growth?
When I'm evaluating a child for growth in the endocrine clinic, I think of three broad questions, and I tell this to families every time I see them. Okay, so one, you're worried that you might be short, but are you actually short? And there's a medical definition of short stature. The second is, are you short for family? So if your mom is short and your dad is short and your grandpas are short and your grandmas are short and you are also growing along that same trajectory, then you most likely do not have a disease. You most likely have a short family.
Yeah.
And then we think about the rate of growth. And that last one is actually the most important variable. If you've always been chugging along, say, the 5th percentile, it's very unlikely that now you're still at the 5th percentile, that something's gone wrong in your growth. So stepping back to that, are you short or are you not short? Short stature, it kind of means something different to everybody. Stature is a distribution. It's a bell curve distribution of heights. And some people are tall and some people are short. So it goes all the way from the 97th percentile to the 3rd percentile. And so people above the 97th percentile are abnormal. Right?
Yes. They're
they don't often complain to me, but they would be considered abnormal. And then people are below the 3rd percentile, then that would be abnormal. But it means, yes, you're short.
Yep.
That doesn't necessarily mean you have a disease.
That's correct.
It just means somebody has to be at the 1st percentile mathematically.
Yes. There's a range.
There's a range. There's a range of healthy bodies. And even if you're on the low side of the range, if other people are taller than you, it doesn't mean that you have a disease. But it is part of our sort of red flag evaluation. So there are 3 possible red flags you could get. Am I short? Yes or no. Are you below the third percentile? Yes or no? And then we'll look at your mom and dad and your family members, because if everybody in your family is below the third percentile, then we're less alarmed, right? And then we really heavily weight the rate of growth. But there are several variables that can affect the rate of growth, and one of the most important is puberty. So an endocrine clinic, particularly in the case of the caller, if that child is at the age of about puberty, and what's actually happening is all the other kids are going into puberty, and your child is still growing at a normal pre-pubertal rate, there's not necessarily anything wrong with your child's
Anything
growth.
to be worried about.
Right.
It's just that they haven't hit that
Right.
part of their development yet.
Right. And, there is, if it's been way too long and puberty still hasn't happened, then maybe puberty's the problem.
Yeah.
But we would do a puberty and growth evaluation. Those always come in hand in that age group. So for girls, puberty can be normal as early as 8, but the average in the United States is 10 years old. And for boys, puberty can be normal as early as 9, but the average in the United States is age 11. So if this is a 12-year-old boy who hasn't yet started into puberty and all his friends feel taller than him, it could very well be that he's a slow grower or late bloomer.
Late bloomer, yeah.
Yeah.
We've heard that term before.
Right.
It just means they haven't hit puberty yet, which
Right.
is when you get an accelerated amount of growth.
100%.
Yeah.
Yeah.
Yeah. I have 2 teenagers, a preteen and a teen, and puberty is an interesting time period as a parent. So I'm learning all about it.
Right, and that too is inherited from your family. So if mom and dad had slower than average puberty, or if mom and dad were late bloomers, then most likely their kids are late bloomers. If mom and dad had early puberty, then most likely their child might follow the same pattern.
Yeah. So there's a little bit of a familial component to that, helping to evaluate that.
Yeah.
Just like height is.
Right, and I think that that's maybe why I encourage families not to comment too much on a child's height.
Yes.
If or their friend's height. Because it could be that you are looking at your kids and their group of friends, and one of them seems really tall. Oh, Sarah, you're so tall. You're going to play basketball, aren't you? But maybe Sarah's just having a little bit of an early puberty, and she's actually going to be maybe even shorter than her friends in the end.
Yeah.
So best as adults just to not comment about other people's heights as much as possible, because kids have enough stress.
Yeah, they don't need one other thing to worry about. And in particular, this actually brings up the culture. Obviously, I'm on the lower end of the height spectrum, but there are, I think there's so much pressure within our society to look at height as something that the taller you are, the better it is to be. I think we have an opportunity, I guess I should say, as parents to help raise our kids to not focus on height, but rather to focus on just their overall bone health and sort of helping to normalize the range of heights.
Right. Everybody's body is different. And as soon as we could all accept that, it would take a lot of pressure off our children.
When you meet a child who, parents may be really worried about height, and if you've eliminated that there's not something medically to correct, how do what kinds of things do you say to reassure families?
Our evaluation for height is more than 3 questions. Those are just the 3 red flags that I think are easy to help us remember. But we're also asking, are you having any associated symptoms with your concern about growth? Those 3 questions are broadly to say, should we be concerned about growth? And then say you have some red flags. Okay, then what are we going to do? We're going to ask what you eat, how much you play outside, what's your sun exposure, how much physical activity are you able to do, what's your medical history? Were you born premature? Do you have any other medical conditions? Are you having any other symptoms? So sometimes when a child is not growing well, maybe it's because their thyroid isn't working right. The thyroid is a gland in your neck that roughly controls your metabolism. And I think about it as the gas in the car. So if your thyroid's not giving you enough gas for your body, then maybe you're not growing well because of that. So thyroid evaluation is usually part of the blood work that we would do if a child wasn't growing at the proper rate. We also do a very thorough physical exam, try to figure out, is there any other key that could be going on? We ask a lot about nutrition. We ask a lot about symptoms of abdominal pain because celiac disease is really common and it can go undiagnosed. And the way that can manifest is your child is growing slower. So that's part of our blood work evaluation. And then sometimes we get imaging.
Okay.
So we can actually take an x-ray of the left hand.
Yep.
And why are we taking an x-ray of your hand in order to think about how tall you are?
Yep.
It's because there's a lot of growth plates in the bones in the hand. And what we're looking at is to actually visualize the amount of cartilage that's still open. Because if I were to take an x-ray of your hand or my hand, it would be total bone. There wouldn't be any cartilage plates still left.
Because cartilage in the growth plates is where your bones grow from, right?
Yeah. Our growth plates closed a long time ago.
Yes, unfortunately.
Yeah. But we can measure it as doctors, and I can say, oh, look how, you're 10 years old and you're feeling short right now, but you have the bones of an 8-year-old. So think how much more growth potential is really hidden inside your skeleton.
Yep.
And so that's what's called a bone age. That's what that tells us. And if we're worried, on the other hand, about bone strength, we might get what's called a bone densitometry scan or a DEXA. And that's a really rapid, low radiation scan that goes right over the child. It's not scary. The DEXA technologists are super
like an
friendly.
MRI with the boom,
not
boom,
like
boom.
no big scary sounds. It doesn't trap you in anything, but it gives us a sense of how much mineral is there and how much does your child have compared to other kids their age.
That's great. So we have lots of tests, lots of things to think about when we're looking at bone health and looking at how is the bone growing and how strong is the bone. Those sort of being two really important signs for your overall bone health, right?
Right. And so I think if I can tell parents, like, look, I got all of these labs and your thyroid was healthy, you do not have celiac, you're not having anemia, your blood work looks great, your growth parameters look good to me, that is reassuring. If I can show that the growth is still there in the bones. And then if we have the honest, candid conversation about, like, look, your puberty was a little bit late or dad's puberty was a little bit late, we just need to give it time. It's going to make the middle school dance really awkward. But in the end, your child is going to be in a healthy place. Then it's not worth any intervention because we could do more harm than good by trying to fix what is just a different pattern or a natural variation of growth.
Yep. Don't want to fix something that's not broken.
Right.
Okay, so let's get back to our parent question from Grace. What are the things that we need to think about when we're looking at a child's growth?
We can test for the downstream effects of growth hormone in the blood.
Yep.
And one of those hormones is called IGF-1, or insulin-like growth factor 1. Unfortunately, the IGF-1 level can be lower in people with poor nutrition. So if nutrition is the cause, that can add a little bit of an extra
complexity
mystery there. But we're not just looking at a child's height in isolation. We're looking at their height compared to their weight.
Yep.
We do an evaluation over time. So particularly if the weight started to fall off first, or if there's any other symptoms, abdominal pain, diarrhea, constipation, that might push us more towards, this might be a primary problem of the weight, and then the growth is just suffering.
Suffering, secondary.
Yes, because when something is a growth hormone problem, there's no problem gaining weight. And so what actually tends to happen is that kids gain a lot of weight relative to their height. Because their height has stopped, but the weight has kept going. So that will result in a larger person.
Yeah, from a mass perspective.
Thank you. You gain weight disproportionate to the height, and the height is slowed down, as opposed to a very thin child who's also then started to slow in their growth. You can't just look at one piece in isolation. You're always having to compare to the weight to the height and the measurements over time and the child to their family. It's complicated.
It's complicated.
Yeah. That's why it's fun.
That's why it's fun. I love it. Yeah, that's what makes you so smart. So, so tell us a little bit more about the Bone Health Program and how that works.
Absolutely. Obviously, they're endocrinologists, but we work closely with nutrition, physical therapy, occupational therapy, orthopedics, and that can be both for bracing and for surgeries, radiology, and the DEXA team for bone density testing. We also work with social work and to get patients the equipment they need to be their best selves. So it's a big multidisciplinary team, and it's why I really enjoy working there.
That's great. When should parents think about seeking out a bone specialist?
I think a lot of our consultations come from the pediatrician. The pediatricians are very excellent at monitoring the healthy growth of children. And so if there's a concern that a child is fracturing too many times or that their rate of growth is not what it should be for their age, then they will refer to the Bone Health Program. Sometimes kids get referred to us because they have imaging of the skeleton for some other reason. Maybe there was a pneumonia in a child and the radiologist astutely observed that these bones don't look as strong as maybe they should on this chest x-ray. And that will send a child to us for more formal evaluation and testing.
Yeah, so really, again, it goes back to how we started the podcast with the two categories of thinking about healthy bones, right? So it's how they're growing and how strong they are. And if you have problems with either of those, then that's a good time to think about seeing a specialist like you.
That's absolutely true. So we support all children, really, and including athletes. So there's actually a female athlete program that's not part of the endocrine bone clinic, but we do work and collaborate with that team, and we're the team that does their bone density assessments for them. So we're happy to get to collaborate there. We also work with other specialists throughout the hospital. So we're frequently getting referrals from neurology, from the cerebral palsy clinic, from the neuromuscular clinic, from the eating disorders clinic, from adolescent medicine. So the skeleton is so critical because it is impacted by all these other conditions that may affect a child's health.
Yeah, and it makes sense that, I mean, even sort of a sports program would really want to tap into your expertise because I would imagine that those kids put a lot of extra strain on their skeleton, and it's important to maintain good health there.
100%. It facilitates the athlete. And we're lucky enough to be at Boston Children's where we have even a specialized team that takes care of the athletes, which isn't me. But I'm glad to be able to collaborate with them.
Out of all of those many specialists, I imagine that the orthopedists are one of the specialists that you work really closely with. Being a bone health patient myself, my orthopedist and I were very close.
No, you're totally right. They're 100% central. The people who actually help us with the structure of the bone and who are there for a child in those urgent type situations are our orthopedic team, because they're the surgeons that can go in and physically fix the bone. And then they frequently, after repairing the child, send them to me to ask the question, hey, Dr. Renthal, why did this happen?
Yes.
What were the risk factors that led to the break? But the team that is your immediate go-to rescue are our orthopedic team, our emergency medicine team, those primary care physicians. And then we're the secondary team, really, that comes in and says, hey, wait a second, why did this happen?
Yeah.
Were there any underlying risk factors? So frequently people tease me like, but you're a bone doctor. And it's like, yes, and I'm the hormonal bone doctor. Asking the whys.
Asking the whys. I love it. And also that is important because it leads to how do we prevent that from happening
100%.
again.
Yeah, I'm here to prevent fractures, not necessarily to acutely treat them.
What I love to hear about that is sort of, the bone health team, they're really looking at what's going on and then helping to maximize overall bone health or prevention.
Like we said in the very beginning of our conversation, the skeleton that a child forms during childhood is the skeleton they're going to have hopefully until they're 80, 90, 100 years old, right? So if we discover a problem with their growth hormone, or we discover a problem with the thyroid hormone, or we discover celiac disease, then we treat those things in the moment and get you right back on course for a healthy, strong skeleton for life.
Such an important part of our body that we can't forget or ignore. So I'd love to transition now a little bit, Dr. Renthal, to understanding what kind of research is going on currently related to bone health.
Awesome. Lots of research. So we at Boston Children's Hospital, we're actively engaged in both clinical research and basic science research, and of course, translational research, taking the things that we understand from bench science into patient care. In basic science, we're thinking like, what's going on at the cellular level? And sometimes we're even looking at inside the cell. So I'm really interested in the chondrocytes of the growth plate. How do those chondrocytes know how many times they get to multiply? When do they learn that they're supposed to stop growing? Why is your femur a really big bone and it knew to grow that big, but your finger only tiny and it stopped? You wouldn't want your finger to grow as big as your leg. So how are the cells knowing that, which can have to do with their genes, the way they make RNA, the way they make protein, and the way that cells talk to each other, maybe even in a cell culture dish in my lab.
Yep.
So that would be like basic science, but we observe things from patients. Like we might discover that a patient has a particular genetic mutation, and then I take that information with their permission, of course, and make a version of chondrocytes that we can study in the lab that lets us understand how those type of chondrocytes with that patient's particular mutation proliferate and mature. So that would be like basic science. And then, we would take those findings that maybe it would lead us towards a particular other kind of gene. Maybe that gene has a medicine for it already. So that a treatment. So we can discover new genes that seem important in the growth of skeletons and in the strength of skeletons and find new treatments that then we can take back to patient care. And then there are existing medications, particularly medicines that have been studied and used in adults with osteoporosis for decades now, that haven't yet been used in children, but that reasonably could be safely used in children. And so we're all the time working on clinical trials to advance the medical care of osteoporosis in kids.
So it's really, I think, important for all of us to realize that so much research is going on, and it starts at the level of the cell, or maybe even, inside the cell, all the way, to getting medications, treatments, and care better optimized for our patients.
Absolutely. The more we can understand the way that cells work and the way that cells work with each other, then we can find new therapies to help strengthen bones and help bones grow.
Be healthy.
Yeah.
That's great. As we wrap up, I always love to end by asking our expert if there's anything that we haven't yet addressed related to bone health that you want to make sure our audience knows about.
Yeah, I really want to make sure that I emphasize today that it's about skeletal health. That although growth can be a vital sign for a child, really what we're hoping to achieve in the Bone Health Clinic is skeletal strength, healthy skeletons. It's health, not height.
Yes.
And I think sometimes we as parents can do a disservice to our children focusing so much on their height.
It's like in our culture, right? We associate, being taller as being better. But
And we're
why?
saying to a kid when we first see them after a long time, oh, look how big you've gotten.
Yes.
Oh, you're so tall. You're going to be so tall. And I think that might accidentally miscommunicate to kids that if I don't achieve those things, that I'm not good enough. We want to make sure to avoid over prioritizing height. Everybody's body is different.
Yes.
You have a healthy body. Look at all the great things that you can do.
Focus on the height.
Right.
Yeah, because you're right. It's just like another characteristic of, an individual, a physical characteristic, but it's not related to health. And it's, variable, just like your hair color.
Right.
Right?
Absolutely.
So now on to doctor's orders. This is the part of the show where we prescribe an action that parents can take to help raise healthy kids. Dr. Renthal, what's your doctor's orders for today?
For healthy skeletons, everything in moderation, good nutrition, calcium and vitamin D, some amount of physical activity, and sleep. We didn't really touch on it, but our hormones are secreted in a circadian rhythm, and getting good sleep, low stress life, that really helps your body use its own hormonal signals to optimize the growth and strength of the skeleton.
We all want to have healthy bones.
100%.
Thanks everyone for listening today, and a special thanks to our parent Grace and our guest expert, Dr. Renthal. We are in our second season now of our podcast, so if you've missed any of our earlier episodes, please check them out anywhere where you listen or watch your podcasts. Thank you again for joining, and we will see you next time.